Okay, so let's talk about perfusion part two. This is shocks, multi-organ dysfunction, and DIC. Your exemplars are 16L and 16E. So for this, have your outline. Also, you need to have your shock review table open so that you can use that to, I would use it after you go through this and you've made notes on your outline to fill out because it's name of the shock, what's the common causes, clinical manifestations, what are your treatments, what are your expected outcomes or goals, so SMART goals for your patient, and how would you evaluate. So you can fill that out after you've done this to make sure that you have that content down, thinking through the nursing process. The other thing that you're going to want to look at that I do have in your notes is that shock and hemodynamic table, because we're going to take those subcategories of preload, afterload, contractility and really put them into play here with our shocks. If you haven't looked at that content, you need to stop and go back and look at that and understand preload, afterload, contractility, what we're measuring. CVP is preload, SVR is afterload, CO and CI are contractility, and how we treat patients with low or high values, because we're going to put that into the works here with our shocks. Your book does have DIC in perfusion. That does fall with your clotting that's coming up in a couple of weeks. So it's just easier to talk about it here. So that's what we're going to do. All right, so let's get into it. So, what is shock? Shock is inadequate tissue perfusion. So this results in cellular, metabolic, and hemodynamic problems. And it's really an imbalance between cellular oxygen supply and demand. Okay? It's not just low blood pressure. Certainly all of these are low blood pressure. Mean arterial pressures are less than 65, which is why you had to learn that. But it's fundamentally the metabolism of your cells. So think of the cells at the tip of your toes and the tip of your nose are having problems. So what's shock result from? Ineffective cardiac function, which can be cardiogenic shock and actually obstructive shock, because obstructive shock is there's an obstruction, the blood can't move to where it needs to because of an obstruction. Inadequate blood volume, so that means I don't have enough volume, whether it's blood or fluid. That certainly is hypovolemic shock. And then inadequate vascular tone is talking about your vascular tone, or like your SVR. And that is distributive shock. And the three types of distributive shock is anaphylaxis, sepsis, and neurogenic. So I know that there's a lot here, but fundamentally you already know a lot about most of these. So that will make it easier. Also, please follow along in the outline. I teach this differently in a different setup and way than the book has it, because I found over the years this is so much easier. It's easier to talk about the type of shocks, and then we'll just come back and talk about the stages of shock. Stages are important because it's helping you with the pathophysiology of what's going on with these shocks. And remember those compensatory mechanisms of heart beat harder and deeper, lungs breathe deeper and faster, vasculature vasoconstrict are all the same for all of these shocks. So we have those compensatory mechanisms going on, and then certainly our RAS system kicks in and we retain fluid and sodium to help with a volume issue, because fundamentally your body, your baroreceptors don't know what the problem is, but it's going to make everything work to fix it. So cardiac function it's going to work on. It's going to work on blood volume, and it's going to work on vascular tone. Okay. Whoops. Let me go to hypovolemic shock. I tried to skip ahead a slide. So let's talk about hypovolemic shock. So the most common cause is hemorrhage. We can have internal fluid shifts, so think of things like burns or just volume shifts, but certainly we see those in burns. And external fluid loss, so that's hemorrhage, whether that's trauma, my inside blood's laying out there on the sidewalk, loss of blood from GI bleeds or from surgery, or fluid losses from things like nausea, vomiting, diarrhea. Also think of our very young and very old. They do not tolerate volume shifts very well. So we have decreased intravascular volume and decreased venous return coming to the right side of the heart that's impairing our metabolism. So if I have decreased volume coming into the right side of my heart, my preload, my CVP is going to be low. So what do these people look like? Well, these people are going to have altered LOC, all the way from just a little mild confusion to being unresponsive. They're going to have rapid deep respirations, which means they're breathing fast, they're blowing off their PaCO2, and when we breathe fast and blow off our PaCO2, we're in respiratory alkalosis. They're going to have cool, clammy skin, weak, thready pulses, tachycardia, oliguria. I'm not going to make urine if my volume is not full, my cup is not full. I don't get urine output, extra fluid coming out because of that. And certainly that decreased CVP. So what are we going to do for these people? We certainly need to get IV access. Now, your book does talk about a 14 to a 16 gauge needle, which is great if I've got to give a large volume of fluid and blood. But if the only thing you can get in is a 20 gauge, then we're going to put a 20 gauge IV in. We may need a central line so that we can give more fluid easier and faster through a central line, and also to monitor our CVP, because any central line can allow for CVP monitoring. So how are we going to fix these people? Well, fundamentally, they have fluid volume loss. So the first thing we're going to give them is fluid, either normal saline or LR. LR is becoming our fluid of choice because not only is it volume, it also has some electrolytes in it. If it's a bleeding problem, we're going to give them blood and blood products. So we will give PRBC, so packed red blood cells. We could give them FFP, fresh frozen plasma, which contains your clotting factors. And we may give them some platelets, because if they are continuously bleeding and we're depleting our clotting factors and our platelets, we need those to stop the bleeding, because fundamentally we've got to stop whatever this issue is of fluid loss for us to gain some grounds. So we can give them blood and blood products. And then what we may also end up having to do is using vasopressors to help maintain that perfusion. But first we have to fill it. So as we're talking about these different kinds of shocks, this is where, when you've learned that hemodynamic piece, how to treat it and those medications, then you fundamentally know how to treat these patients in hypovolemic shock. And certainly we will give them oxygen as well. Another treatment we can do is what's called reverse Trendelenburg, which is what this JPEG on your screen is, and that is elevating their feet but not having to put their head down. You've got a lot of volume in your legs, and that will help send that to the central part of their body and help increase their mean arterial pressure and allow them to get more perfusion. So as you think about these shocks, think about what's causing it, what do they look like, so what's your assessment, what do you have to analyze, what labs would tell you. Certainly if I have a bleeding problem, I'm going to look at labs like H&H. But if I have nausea, vomiting, diarrhea, I can still look at a hematocrit, which will be high because that they're dry. And I can look at things like BUN, which will elevate if you're dehydrated. If I don't fix this problem, then it can lead to other things like multi-organ dysfunction from lack of perfusion. How are you going to treat these patients? What are appropriate goals for these patients? And then how do you evaluate that your treatments were successful? One quick note about blood loss. There's usually not a real standard. Your book does talk about more than a liter, and that's actually a lot of blood loss. I think of about 500 mils. More than that, I'm starting to get worried for my patient because a unit of blood is somewhere between 300 and 350 mils. So at 500, I'm almost at 2 units down. That's where I'm starting to have trouble. And certainly, our very old and very young will have clinical manifestations and problems much earlier. And so we need to recognize that. All right, let's move on to cardiogenic shock. This is failure of the heart to pump efficiently, which means I have decreased myocardial contractility because the heart's not working for whatever reason, which means I have decreased cardiac output and impaired tissue perfusion. Simple. So there's lots of causes. I've picked some of the main ones. Number one, the most common reason people are in cardiogenic shock is from a myocardial infarction. It could be dysrhythmias. So fundamentally, if we get rid of the dysrhythmias, they won't have cardiogenic shock. Valvular dysfunction, so think of severe aortic stenosis where the aortic valve is very tight. It's difficult to get blood through it, which means I have decreased cardiac output going to my body. Or cardiomyopathies where my heart is big and it doesn't pump well because a big heart doesn't pump well and it doesn't conduct correctly and they have lots of dysrhythmias. So clinical manifestations for these patients. So certainly they're going to be tachycardic, tachypneic. They will have altered LOC and altered mental status. They're going to have decreased urine output. They're going to have weak, thready pulses. They're going to have a prolonged cap refill. They will have cool, clammy skins. They may have dysrhythmias just because of poor perfusion to the heart. And they can have chest pain and chest discomfort. And fundamentally, these patients will have fluid volume overload issues. So when you think of cardiogenic shock, this is heart failure and somebody trying to die right now. So they're going to have left-sided, if it's a left-sided issue, a left ventricular issue, they're going to have S3, S4, crackles, dyspnea, hypoxemia. If it's a right-sided failure, they're going to have JVD because that blood is having trouble getting back into the heart. It's backing up because it's not pumping well. Peripheral edema and hepatomegaly. So how are we going to treat these patients? We are going to find the cause and treat the cause. So if it's an acute MI, they need to go to the cath lab and have a PCI. They may need to go to bypass surgery. If this is a valvular dysfunction cause, then we need to fix their valve. Cardiomyopathies are much more difficult. We have to just treat all those signs and symptoms. We may also do what's called a cardiac assist device. So I will call those left ventricular assist device or LVADs. And we have two different ones that we're going to see. One's called an Impella. So you have a little short video that describes what an Impella is, and we see that most frequently. And we may also see what we call a balloon pump, an aortic balloon pump, and it's literally a large balloon that sits in the aorta that's going to inflate during diastole, deflate during systole. And the purpose of these left ventricular devices is to help pull blood out of the body and to perfuse vital organs. They are implanted in a femoral artery, so we need to watch that site and watch for complications. So what you think of is, oh, that's like a heart cath, and I already know what to do with that. They will have to remain on bed rest. They might have their head of bed elevated a tiny bit, like 10 to 15 degrees. Now we can do an Impella, that type of LVAD, longer term, because these are really short term. These are several days while we're waiting for the heart to rest or recover for surgery or get strong enough so that we can take them to surgery. We can do an Impella through the subclavian where they can get up and move around. That is actually a bridge to waiting for transplant. And then we certainly have patients with long-term implanted LVADs that go home with those devices. That is their bridge to surgery. The other treatments that we need to think about is their hemodynamics, and so we're going to need to treat this increased preload because cardiogenic shock has increased preload, so we may give them a diuretic. We could give them a vasodilator like nitroglycerin or nitroprusside to dilate to displace that fluid, but you have to think about what is their MAP, what's their cardiac output cardiac index, and it's probably low. Do they have enough MAP to tolerate a vasodilator? We might also give them an inotrope, or what your book talks about as cardiac glycoside, to help the heart pump better. So fundamentally, we could give them digoxin. Not an emergency med. We're not seeing it very often, but it's still showing up everywhere because dig has a real small therapeutic window. People can become toxic on it, and they can have nausea, vomiting is the most common one. They can see yellow, that's pretty common, and we may need to treat that. But the big ones that we're really going to see in the unit, which are given IV drip, are milrinone, dobutamine, and dopamine. So milrinone, dobutamine, and dopamine. These come right off your hemodynamic information. Remember, dopamine increases heart rate, so cardiac output is stroke volume, how much times heart rate, how fast, gives me more cardiac output. So it does work, but these patients are going to already be tachycardic, so we do have to be mindful of if they have heart rates of 120, 130, if we start them on dopamine, they're going to be in the heart rates of 140, 150, and they won't tolerate it, which may be why we see dobutamine. Your healthcare provider will order that. We just need to watch for those effects. So when you think about how to treat cardiogenic shock, look at your hemodynamics and understand what we need to work with. We will certainly take care of volume, so they may get Lasix just scheduled. We could also give them that diuretic, namely furosemide, in an IV, continuous IV infusion. And if I'm going to give them a diuretic, you should check their potassium. All right, I'm going to end this one with what we've discussed, and we will come back with part 2 and start on distributive shocks.